Welcome everyone here. It's Dr. Doraid Matani. I'm the CEO and founder of Novimedgroup and the head of staff and founder of Valitracks as well. We will be discussing today the shift that we foresee and that we think should be happening in the near future for linguistic validation. We think that linguistic validation process should be becoming slowly a centralized process that is digitalized, as well as many processes in the industry using and utilizing the tools that we have. So let me introduce the webinar topics. We will have 3 topics here that we will be covering, and we will start with them as follows. So let me share the screen with you. So linguistic validation is basically a process that is accepted in when dealing with linguistic services for COA instruments, basically clinical outcome assessment instruments, and it's a very complicated and long process. So we will be covering the methodology and the approaches towards this process, which is a spectrum that we would like to shed a light on over here, and then we would go to the challenges that we at Novimedgroup see, and as well as other researchers in peer-reviewed pages and publications that have been reported in the last decades. So, and then eventually I will be covering Valitracks, our software, and I will try to link into this and give you our perspective of the whole challenge here. So let's jump into this. So linguistic validation basically is divided into 4 parts. We have the forward translation part, the reconciled version part, the back translation, and the revision, and then the in-field testing, which is usually actual interviews, face-to-face interview, which is called cognitive debriefing, or we have clinicians review. It depends on the instrument that we are testing. So if we go for forward translation, then we have usually 2 forward translators that they try to convert or create a first version of the questionnaire or of the instrument in their language. So they should be native usually, with some background or experience in preferably in the domain, and they will create 2 versions. Then they will be checked by another professional that will try to create the reconciled version that we will cover in the next step. So I don't want now to go to the specificities of forward translation in this, but I would like to show you what is the management challenge of such a project. So when a questionnaire developer is dealing with his own research in the domain, the medical domain, the psychometric tests, he has to deal also with so many steps that we can see here. So the forward translation is not performed in one place. Every provider has his own CAT tool. Every provider might be using other methodology, communicating between the parties involved in this process, whether it's a virtual call, email, and it's really difficult for the study leader to follow up on all of this. Of course, there are terminology dictionaries that might be different from each and every domain, instructions that are different for the translators. They need to be debriefed, they need to be guided. There is a discussion, there should be a documentation of the discussion. All of this is lots of data that we give for the project managers, which are human, as good as they are human, and they have to deal with many platforms and many entities, and this just gives so much space to mistakes which happen. So this is the first. Second thing is the reconciled version. Of course, here we have the same thing, the different platforms, the documentation that is happening or not happening depending on the provider. And there are so many approaches also toward this step. Many developers give the translator that is creating this version the freedom to add sections, for example, to rewrite the whole pieces of translation. So there is so much into this, and it's not something stable. So this adds another challenge to the project manager, to the translators, and we have a chaos basically many times in dealing and in organizing the whole spectrum of activity that's going on here. And especially if we speak about COA developers, which are dealing with not one provider but many providers in different countries, different practices, and it's very difficult to put all this together in the time frame that we have. So that's another thing, that's another challenge. The back translation, again, it's the same idea. We have after the reconciled version was performed, the two translations were merged, let's say, and there was a consensus version created by the translator. There is another step in which the translator tries to convert the translation from the translated language to the source language. It's another translator, of course, and it's another one to deal with, to speak with, to communicate with, to document the comments of, the dilemmas of. And again, it adds another layer of complexity, of place for mistake, difficulty to follow up. All this is correct. So that's another step, another challenge here. I would like to continue here to the in-field testing. So the in-field testing is usually what we call cognitive debriefing or clinicians review, and basic or both together. Many times they can happen also together. So basically we try to test those questionnaires or instruments on the real players in the industry that are the subject of those instruments. So if we speak about PROs, that's patients, because it's patient-reported outcomes. Observers reported outcomes, that might be observer, family member of the patient, parent, etc., etc. So all these instruments are assessed in a not unified methodology, I would say, but in a cognitive interview in which the interviewer tries to grasp the difficulties, the challenges that they might have with this questionnaire. Of course, as I said, there are different approaches in this also. We have a face-to-face interview versus a virtual interview, discussion or brainstorming between the interviewer and the translators and the researchers. Many might ask for follow-up questions. Many might ask for also for documentation. Some would not ask for documentation. All this is performed on so many platforms, whether it's email, whether it's phone, whether it's going physically there and meeting the patient and afterwards filling Excel sheets or CAD tools. So it's a chaos again here, even a bigger one when we speak about summary reports, which are very broad spectrum of summary reports with very little knowledge sometimes from the interviewers to understand the structure of what this summary report means. And all this is attributed to, in some cases at least, to the fact that there are too many platforms, too many steps for a human to conceive and to be able to control. And this is just the nature of humans. And therefore, we are heading to our software at the end of this presentation. I hope I was able to cover some of these, let's say, approaches, or I would call it methodologies, in each of the main steps of the linguistic validation process. So let me cover now some challenges that have been actually reported in the literature. Detcher performed a systematic review of 70 dementia-specific quality of life measurements, and those 70 had a lack of internal validity. Internal validity is actually a psychometric, let's call it, a measurement that COA developer tend to use in quality of life measurements. They run some statistical tests and they try to understand the reliability of the answers of participants within a group of symptoms. For example, if we ask a patient, for example, whether he's depressed, we can ask him in 10 different ways this question. And if there is no consistency in the answers, this might show that the concept was not understood and that there is more to do in this case. So this is another issue that appears here in linguistic validation. And the issue is here that it does not mean that if we research the COA in the source language, it's not enough to perform the basic linguistic validation process many times. And we have to apply psychometric tests and even in some statistical tests to check the validity and the reliability of our products. And frankly, with such a complex process, it's really difficult to do so because of so many steps, so many potentials for mistakes and for delays. It's just normal that this is not possible in many cases. And therefore, as we see here, Detcher and Pierce just show that 70 linguistic validation instruments, they were basically unreliable, useless, although so much time was invested in, because of the fact that we did not focus on the more scientific side of it, and we were not able to perform the appropriate number of studies and researches on each and every segment or piece of this validation. Another research was performed by Kennedy and Pierce, and it's a really interesting topic that reflects the difficulty that linguistic validation as a linguistic research poses, because this is the meeting point of it with the clinical research. And actually, when we speak here about specifically Alagille syndrome, for those of you that are not familiar with Alagille syndrome, it's a genetic disorder in which children are born with less bile ducts. Bile ducts are those ducts that extract the bile acids to the bile system and eventually to our feces. That's why our feces are not white, let's say. Those children have maldevelopment of those. They don't have enough bile ducts, and therefore they unfortunately have low life expectancy. It's a very rare disease. They reach end stage liver disease in around 20 years old, and it's really difficult to recruit patients with Alagille syndrome. And therefore, here in this research, we saw that the linguistic validation was performed in many steps with delays, of course. First, the researcher had to expand the age group, and then even that was not enough, and they had to give access or recruit patients that have similar symptoms with no clinical similarity, in my opinion at least. They recruited atopic dermatitis patients with similar scratching symptoms, but nothing to be compared with in the context of a life-threatening disease like Alagille, which is a very, very serious disease. So anyway, I'm not criticizing here the authors or the researchers. I'm just saying that recruitment is a very, very important issue here, and we have to join our forces here, because actually in the field of linguistic validation we are a group of groups, and we have no straightforward access one to the other's resources, and we should have that as in clinical research in many ways, and this is one of the goals of Valitracks. So let me just continue with this. So another topic here is a research that was performed by Seventer and the peers, and they researched the French neuropathic pain instrument that was translated to German. So basically, what they describe here is that the instrument, when it was back translated to after it was translated to German from French, it was again back translated for the team that speak French. It was back translated so that the team that speaks French understands it, and then it was compared, the back translation of the French to the original French, and it was really similar, 96% similarity. However, after as we are familiar in clinical medicine also, the facts that we have in books or in, let's say, laboratory are not any similar to the real in-field testing, real world cases. So this is the case here also. There were more than 50, if I remember well, changes suggested by the participants. Many are like pins and needles, for example, have not been understood in the cultural context by German speakers. Therefore, this shows the complexity that we face many times when dealing with cognitive debriefing, that we cannot expect what will happen when we start to test those instruments, and to have a built-in process and to be able to stabilize, let's say, the variants that we're able to stabilize so that we can absorb and research in a better way those variants that we're not able to stabilize, and to have to be calm that they're okay. And this is a very essential thing. And okay, let me move on, and then I will connect it together. So we would like to speak about our perspective. You already, from what I'm saying here, I'm sure understood where I'm going and what do I prefer, but let me say that we think that the challenges are because of the multi-process translation. In this, we many times see, because of time delays, because of, for example, many times providers might have some difficulties understanding, and there's a back and forth between the provider and the translator. There's many data that is lost, and if you come back and you try to understand what happened 5 years after that, you cannot really understand what's going on. So this is just one of the things. I'm sorry. Another thing is that it's a multi-platform process, very difficult to manage, very time-consuming. Another thing is that there is a constant need for communication and reporting. There's a need for documentation, which in clinical medicine we are used to, but linguists are not used to this, and it's very difficult to make them used to. And then there's a discussion and the explanation, and that's another step that is very challenging. As we said, in vivo testing is very challenging with the recruitment, the interview, the methodology of the interview, each interviewer's abilities and disabilities, the documentation again, the discussion and the follow-up, and the final summary and paper publication. All of these with statistics, all of these are very challenging things that vary very much between one provider and the other, one process and the other, one domain and the other. And these are things that we have to try to stabilize the channels that they are performed in, and build our own processes so that we can focus on the real issues, the scientific issues, like we saw in the paper published about this about this systematic review, about those 70 quality of life instruments that were basically not properly linguistically validated. We don't want those scenarios to happen. And this brings me to our solutions. So our solutions are basically a discussion, a professional discussion between all players in the industry, all professionals, and we have to try to unify the methodology as possible. Of course, we cannot unify the whole methodology because it differs between diseases, between instruments, what they are addressing, what they are used for, researchers' preferences, many things. But we still can build paths for each and every research so that we can have a clear path, and we have to focus only on the scientific aspect of it. Enhancing documentation, that's the first thing that I understood when we started with the linguistic validation about 10 years ago. The documentation was awful. It was scattered everywhere. You needed one day only to read the papers, and many times many data was lost. We think also that creating a social network of COA development, of developer companies, linguistic validation providers, patients or participants, or potential patients and participants, potential clinicians or healthcare collaborators in the process, regulators, and most importantly, data sharing between the different companies. So we think that data share between different providers is a very important thing. We think that this can be helpful in understanding some challenges before building the study, and while in the study we can also share or learn from one from the other. So there are many solutions that we can provide in this case. As I said, we would like to enhance the inter and intra organizational communication and to build a dedicated professional teams. Of course, that's correct for today, and that was correct before. But when you have documentation and you have the follow-up, the clear follow-up, it's much easier to be able to build professional teams and know who is doing the job properly and who is not, and we should cut it. I'm sorry. So, what is Valitracks and what functionalities does it have? So, Valitracks is a cloud-based software that was built this year, and we started the development of Valitracks 2 years ago. The idea of Valitracks came with the pandemic when we started to do virtual cognitive debriefings. We started to have real issues meeting the people, and we really needed some professional platform that can access the patients in a professional way, gather informed consent from them, be able to maybe record them with if they agree, be able to process all this information, provide this to the client without back and forth in emails, and have a real focus on the research itself. So we built Valitracks. So Valitracks is a cloud-based platform. It's customizable in a way that we can provide you different paths depending on the research that you're dealing with. So if we are developing PROs or clinicians reported outcomes, there will be different paths. We can also predetermine before the variables, so we can run psychometric tests, different statistical tests on the platform. It's a multi-platform in one platform, and I will cover that soon. It has interactive forms in a way that the patient does not have to have the whole form in front of him, but each section, while he's interviewed, appears to him in the size and shape that we would like to have. Also, it's very helpful with people with the problems in their with the sight problems and with hearing problems. We have an automatic process that produces documentation reports. We can provide all the logs and all the comments provided in the discussions between the teams, so nothing gets lost and everything is automated. We have the ability to voice record, to extract the voice recording from the virtual meeting between the providers. We have a customized CAT tool that is built in for Valitracks. We have a live follow-up from any device, anywhere. You can access your linguistic validation process. You can see where is it. You don't have to send emails to your providers and ask them where are they with the translation. Everything is clear. Summary reports are, again, it's customizable. You can generate your own form of summary report. Our team will make sure that it is what it suits you. There is a discussion platform, as we said, and there is a social network that we are building now. Everyone that signs up, we have a channel to channel him into, and of course everything is done with consent, but we are building a social network between all of the participants in the industry, so that also this can be used to recruit patients, to recruit professionals and interviewers and clinicians, and also to share data. And this brings me to deep learning that we're building. We are building algorithms to try to understand the challenges that we had in the past. We try to build the correct process for each and every COA development and or a linguistic validation process. We try to have a built-in paper publishing platform, so that when you publish your papers, it's already ready for you, so that you don't have to add more days of work. So all this is in. Of course, there is the communication between the entities that we're building. We welcome you to bring your data, your past interviews there, and you can inside your organization have your discussion and have a research the whole processes that have been performed in the last years. Or you can also try to collaborate with other entities, so that they research your data and they can give you some insights. All this is under development, the deep learning part. All the other parts are already existing and they are there. Sorry. So, functionalities. So as I said, this is a dashboard of Valitracks, as you see. This is the login dashboard, and there's a built-in CAT tool that is able to basically give you the access to translation while your translator is performing it. You can see where he progressed, you can comment on it. There is a video conferencing tool for the cognitive debriefing, or also for the follow-up. There is a documentation tool that documents the whole comments and discussion issues, version creation. There is a multi-step process, as you see here on the left. That's part of our dashboard here. You can see that there are translation. You can see the translation merger, or the creation of the reconciled translation, back translation, revision. So every step has its own place. Then we have here the CAT tool. This is how the CAT tool looks like. It creates more than one version. You can have a follow-up. You can see it. You can process any file you want, XLIFF, doc file. Then we have the merger tool. You can see that the translation here are, it brings all the versions, and you can just pick up the version you want and put it here. This is just an example of what you can do. It creates also versions with dates. Of course, it extracts automatically the reconciled version, or the version that you would like to back translate, and it gives you a back translation. You can live follow up this. You can separate access to the entities, so that the back translator has no access, of course, to the source language, and you can have the whole discussion there, which will be extracted and documented as well. This is one of the dashboards of the cognitive debriefing. Here you can see that we have in-house patients, which are your own patients or interviewers, and we have here the valid or validated patients that we can provide you in case we have the access to patients that express their consent to contact them. Depending on the pathology, the age, etc., etc. Here you can see the dashboard of the cognitive debriefing interview. You can see that here you can have a camera or off-camera interview. You can have a messaging system that you can message your patient and speak with them there if you have any issues connecting. You have a direct email or phone also connection with them. It's an interactive platform. You can see that we are asking one question by the other, not all together, and beforehand he can provide the consent. He can see the whole questionnaire before they provide the consent. It's a really complicated it's a really easy to use, however a complicated process that we made it very, very accessible even to people that are not technology oriented. It's really easy to use. Audio recording, of course, with the consent of the patient, you don't have to actually audio record it. It can automatically audio record when you give it before the interview. You can give it yes, and then it will audio record you. It's possible also to audio mask the voice of the patient so that it's not recognizable. Every user has his own interface. You can create, as we said, summary reports. You can customize them. You can check the usability of the ECOA instruments. You can use any design you want. We can show it and share the screen with the patient over their phone, laptop, tablet, whatever it is. It's possible to do. We have the track also of the device. We can know what device they're using and make sure that we are really testing what is needed to be tested. And we also give you automatic statistical report depending on the variants that we predetermined in the questionnaire building stage at the beginning of your study. And of course there is a follow-up, but that's very good also for the statistics and also for the real life. So if you run a test-retest statistic testing, you can just follow up with a click with your patient and ask them the same questions again and see if there are variations with their answers. Also, if there are things that they do not understand or things that are not clear in the recording or the interview, you can follow up on them. Also, you have to know that the summary report creation is really straightforward, and we have an interactive platform for the interviewers so that they can fill up immediately while interviewing the patients the different answers that they provided. Sorry. Okay. Okay, so I really covered this in a very, very short and very fast. I'm aware of that. We had some clinical issues. I'm not sure we went live or not. Anyway, if we did not go live, I'm sorry for that. We will try to repost this webinar on our website and on our LinkedIn page. What I wanted to say here is that I invite every one of you, especially COA developers, to come and book a demo with us. We have a limited access now. We cannot give access to everyone, unfortunately. We have to study our collaborations because we try to tunnel our resources to the best development path possible in the next months. But we do open Valitracks now for use of other entities. Because of our successful use in Novimedgroup, we are very enthusiastic to share this with you and to hear your opinion and to develop your customized approaches and even import your previous trials and try to deep learn each trial, each issue that you might have had, so that those don't duplicate in the next studies. That's it. Thank you very much for your listening. You can see here in this slide I provided my email. You can also contact Alexandros for any questions that you might have. And thank you very much. Have a nice afternoon, evening, wherever you are.